comprehensive primary care CPC initiative worked to improve care, improve health, and lower costs for patients and their families in the primary care setting. Nearly 500 primary care practices and more than 2,000 practitioners were enrolled in CPC from 2012 to 2016. The CPC initiative focused on 5 functions of primary care: access and continuity, planned care and population health, risk-stratified care management, patient and caregiver engagement, and coordination of care across a medical neighborhood. This on-demand learning series explores how CPC practices implemented strategies designed to strengthen primary care.
COPD is something that we looked at as one of the highest readmissions that we had in our practice, and something that we thought that we could do something about. It's not 1 or 2 people doing this, but it's a team effort in our entire office. It starts with the people that answer the phone, and it goes all the way to the physician. All of our receptionists, our care guidance nurses, our LPNs, our medical assistants are all involved in the project, and I think it has to be a team effort. The way we got started is just to have our electronic health record generate a list of all of the patients that we had with the diagnosis of COPD, and then each physician sat down with their individual list and picked out a cohort of patients that they thought that this program would be good for. We looked at the severity of their illness. We looked at their ability to follow instructions and be able to participate, their adherence to previous instructions, and also their history of COPD exacerbations. In our packet, we had several things, and I'll kind of briefly go through that. It was primarily a 4-page packet that included information about antibiotics and looking at an overall antibiotic that we could choose for patients that would generally work for almost everyone. We chose doxycycline and amoxicillin. That's something that every office would have to look at for their particular office. And then also the other thing we wanted to include in the rescue pack was steroids. We included medication information cards, the American Lung Association classification list, personalized action plan for each patient, and then the care guidance nurse business card so that they could contact them directly. The care guidance nurse, once we chose these people, had the packet. We put it in actually a folder to give to each patient all of the information, and sat down with the patient individually anywhere from 20 to 30 minutes, depending on the patient, to go over all of this data with them. And then we had some general information about COPD. What is COPD, for instance? We didn't want the patients to get the idea that COPD was something we were going to make go away, because that's impossible. It's a lifelong disease, but that our goal was to provide efficient tools that would help prevent complications, but also slow progression as much as possible. And one thing that we emphasized more than anything in the world is that in this project, the most important person was the patient. If symptoms progressed and they developed 2 or more of the symptoms over a 24-hour period, then we wanted them to start using the medications that we had provided for them. And we gave them the outline of when to start the steroid, when to start the antibiotic. One of the important things in the guideline of this project was that they needed to be seen in the office within 1 to 2 days of onset of symptoms. We wanted them to start their treatment immediately when they recognized the symptoms increasing, but we wanted to see them within 1 or 2 days. It wasn't that we were giving them a course of antibiotics and then deciding, well, should we see or should we not? The mandatory part of this was that we did see them, make sure that they were on appropriate therapy for the symptoms they had, and that we wanted to continue that without making any changes. And we also gave them guidelines that if they exacerbated significantly before we were able to get them in the office, what to look for and when they should call 911 and be seen in the emergency room.
This is our COPD action plan. We did steal this from American Lung Association. It's online. Anybody can go on and get it. The green zone is where the patient is feeling they're normal breathing, no symptoms at all. Here we really instructed them that we want to make sure that they're taking their routine medications, because you will be surprised that a lot of patients don't take their routine medications, and that's one of the big reasons why they were having exacerbations and they just didn't put the two together. The yellow zone is where we went into, okay, I'm starting to have some symptoms, and I would actually number by the action. Number 1, next to increase your rescue inhaler. Then number 2, we would do the prednisone or steroid. And number 3, we would do the antibiotics. And we would let them know if you have one symptom, you start with number 1. If you start to have sputum increase and difficulty breathing, start the prednisone. And then if your sputum starts to change colors or you start having fever, that's when we want you to start the antibiotic. And then the red zone was, of course, if they're having worsening symptoms. At that point, we want them to call 911 and go to the hospital.
They do show a tremendous change in the patients that were in our project. When we looked at it over a comparable period, the blue bar shows how many visits that we had per month from the patients who were involved in this group before we started the rescue pack. We had 1.21 visits per month. That was either an emergency room or a hospitalization. And then following giving them the emergency pack and the things that went along with that, we had a 0.3 hospital contact per month, which worked out to about a 75% reduction in hospital contacts. So with these selected group of patients, I think this project was extremely successful. Our whole goal was to give the patient control, allow them to initiate treatment early in the course, and prevent hospitalizations, and I think we met the goals that we set out with. These are some of the comments from the patients that came in on our survey. I think in general everybody liked it. They enjoyed the control that they had. They were faithful about the follow-up after they started it, and they just enjoyed not having to go to the hospital.
For more information and resources, visit the Comprehensive Primary Care Initiative webpage. Go to innovation.cms.gov and search for the CPC Innovation Model. This has been a production of TMF Health Quality Institute.